Welcome to Monday morning grand rounds, and it's a mess out there, so if you're driving, be careful. I'd like to thank first Janssen Pulmonary Hypertension and Pfizer for their support of us this morning. And I would like to now introduce our grand round speaker this morning, one of the newest members of Minneapolis Heart Institute, having joined us in April. Dr. Hayan Maluli is working now in Waconia and also goes to Baxter to do pulmonary hypertension work there. He's a graduate of Temple University's cardiology training program and came first to, I believe, Grand Forks, North Dakota in the All True system, and then moved south to Fargo with Sanford, and now has come over to the Twin Cities area first at Health Partners, and then we recruited him away from Health Partners. He has a special interest in pulmonary hypertension and is going to address us this morning on building pulmonary hypertension centers in underserved communities. So welcome.
Thank you.
Thank you for coming.
All right. Yeah, I have my mic. Thank you. Thank you, Dr. Sharkey. Thank you, everybody, for being here today, and to everybody who's online. This was a wonderful introduction, and it summarized everything really I have done over the past few years. But pulmonary hypertension is really a passion of mine, and one of my hopes coming to MHI was to expand on this passion and hopefully, do more than I have already done. But I wanted to share about the experience I've had over the past few years and about the state of pulmonary hypertension, essentially, in the United States. Having trained in the East Coast and then moved to the West Coast, first being at an academic center and then being in more of a smaller centers and bigger centers here in the Twin Cities, I think I've had a relatively good sense of what is the care of pulmonary hypertension like in the United States, both in big urban areas and in smaller areas. And so we'll talk a little bit about that, and we'll see how this applies to the care of pulmonary hypertension here in the Twin Cities in general, and MHI in particular. I do not have conflict of interest. They asked me about the last 2 years, so I checked, and nothing in the last 2 years. Maybe before, yes, but not in the last 2 years. And so again, the main objectives, and these may shift as I talk and you ask me questions, but I wanted to explain to you about how pulmonary hypertension patients are cared for in the United States. At least the way I see it, there are no definite, government-based statistics or anything like that. But then we'll talk a little about the challenges of taking care of pulmonary hypertension patients in the country. And I use some complicated verbiage here to deduce and debate some solutions for how we're going to move forward, hopefully. And so how it all began, I was asked about that. I really was confused about pulmonary hypertension in training when I was a medicine resident. It seemed like there's a lot of confusing vocabulary and there's a lot of conflicting information. So I really wanted to learn a little bit more. And then my mentor, Paul Forfia, moved from the University of Pennsylvania. He was the head of pulmonary hypertension there. He moved to Temple, where I trained as I started my fellowship, and he really was a great mentor. And he needed help, obviously, from the fellows, so I was very happy to I spent really a lot of time with him, but it was very, very wonderful for me. It really launched my interest and took it to a whole new level. So I owe everything I know about pulmonary hypertension, or at least 80% of it, to him and 20% to the pulmonologist. I never told him that because he never got along well with the pulmonologist. So I did it on my own. And then the opportunity came to practice pulmonary hypertension. I had to go to the Midwest mainly because of visa issues. But because I liked that, I looked for the opportunity, and it was abound. There was a lot of need, and we'll talk about that. And the need the need comes because pulmonary hypertension is really bad news for the patient. essentially. And that's for multiple reasons. Also, we will talk about them. And so immediately people, when they see someone who does pulmonary hypertension, they realize, okay, this is something we've been looking for, we've been waiting for, we need help. And so they start sending patients, and the practices grew very, very rapidly. So why is pulmonary hypertension bad news? I tried not to put a lot of numbers in the talk, but it's one of those talks that I think is mainly driven by numbers. But I'll try to be brief. But if you talk about pulmonary arterial hypertension, which is what people think when you say pulmonary hypertension, that's mainly what they're trying to say. And that's why the confusion that I had always is, even to this day, there's a lot of people, including cardiologists and pulmonologists, who seem to be a little bit confused about the name. But PAH is in group 1 of pulmonary hypertension and has a high mortality. And this is what we try to weed out of the bulk of the pulmonary hypertension referrals that we get. We try to, extract this group 1 and group 4. There are specific treatments for them. Group 1 is a group of patients that is very, very sick. They have a mortality about 50% at 5 years, which is pretty bad. And it's especially bad because when you think of the median survival at about 3 years, it takes us about 2 to 3 years to find out the diagnosis. And so you think about it, okay, it takes 2 to 3 years to find the diagnosis from the onset of symptoms, but half of them die within 3 years. So you're like, whoa, this is pretty bad. And this hasn't changed over the years. The first NIH registry, which was by Dr. DeLanzo, one of the pulmonologists at Temple in 1991, said it takes 2 years to find the diagnosis, mean time. Reveal, which is the new US registry, it was like 2.8, so it got worse. We're still struggling with pulmonary hypertension. And here's the survival at 3 years. If the patient continues to worsen, they got a 30% survival at 3 years, essentially. Again, this is the Reveal registry. It's a United States-based registry for pulmonary hypertension patients. And this is the problem, or part of the problem here, is that both in Europe and the United States, if you look here, the bulk of the patients here and here, more than 50% of patients, when they present in functional class 3 and 4. And so they present advanced. We see that all the time. We rarely ever see a pulmonary hypertension patient that comes in at an early stage. Usually they're screened by the rheumatologist or someone like that. We're very happy to see them in functional class 2 or even 1. I don't remember last time I saw someone in functional class 1 unless they were misdiagnosed as pulmonary hypertension. But most patients come advanced. And this is important because the survival for functional class 3 and 4 is very, very comparable to advanced metastatic ugly cancer, essentially. So this is why PAH is such a big deal, and this is the why for me in the interest is that, okay, well, this is a poorly understood disease entity. There's not a lot going on for it out there, but it's a very, very serious problem. And so to add to this not very pretty picture, essentially, even when patients with pulmonary arterial hypertension present and you start treatment, when they look at people dying of pulmonary arterial hypertension, about 40% of them, almost half of them, they die of pulmonary arterial hypertension, not on what we call parenteral therapy. Parenteral therapy is like the real therapy for advanced pulmonary hypertension. It's like the chemotherapy for cancer. So imagine 40% of patients with cancer, advanced cancer, die having never been treated with parenteral therapy. So we are vastly undertreating pulmonary arterial hypertension. And this registry extracted patients from pulmonary hypertension centers. So these are at the places where people actually get treated. And I'm going to tell you that the vast bulk of the country, there's no data because nobody is treating. So I promise you, there are a lot of patients who are being missed. There are a lot of patients who are being undertreated, and there are a lot of patients who are mistreated. I think of pulmonary hypertension like pulmonary embolism. We overdiagnose it and we underdiagnose it at the same time. So we really, really, really need to do a much better job at taking care of those patients. But why do we care about statistics, right? There are three types of lies: lies, damn lies, and statistics. But MHI group, Dr. Fenstead, who you worked at MHI up in Lakes area, and a few other people in the practice looked at, okay, well, PAH is really rare, correct? It's rare because we probably underdiagnose it. And their data, for example, said that when they looked at their local population and cath-confirmed pulmonary arterial hypertension, the prevalence is actually at least 10 times higher than what the statistics, the general statistics of pulmonary hypertension in the country states. And so this is a bigger problem than we think. It is a bigger problem than we think. And again, the statistics saying that pulmonary hypertension or pulmonary arterial is rare and this and that, I don't really trust it very much. Maybe I am biased because I've seen it so often. But it's amazing how quickly you build up pulmonary hypertension practice, because it's almost like there's a thirst, there's a huge need, and as soon as someone who does pulmonary hypertension comes and they prove that they know what they're doing, people start sending patients in huge amounts. And I've certainly experienced that, and I'm sure Eric has experienced that. And now I'm taking care of his patients up north, and he's got tens of patients on therapy in a short period of time. So my experience in both North Dakota, smaller center, large center, and in St. Paul, Western Wisconsin, really confirmed that we are underdiagnosing and absolutely undertreating patients with pulmonary hypertension, and absolutely those patients have bad outcome, because this disease is not a stable disease. It does not stabilize. It's not a disease that people go on cruise control. Every pulmonary hypertension or PAH patient will progress to dying of pulmonary arterial hypertension. This is not a cardiomyopathy that could cruise on it for years and years. Patients will die unless they're aggressively treated to very aggressive targets. So, how is pulmonary hypertension cared for in the United States? Mostly in large academic centers, and there are some few scattered providers here and there with different training backgrounds and different styles, and we'll talk a little bit about training for pulmonary hypertension. The way I saw it in the country, having come from East Coast to Midwest, and I've attended many conferences, met many people. It's either there's no PH care, nobody takes care of PH. The hospital could be as big as you want, but then nobody does PH. So what do you do with your patients? We don't know. Well, nobody wants to deal with them. They almost push them away. They're allergic to pulmonary hypertension patients. Or it's there, and I would say MHI probably falls, and I don't want people to get offended, but it exists, but it's secondary to something else. So it's a heart failure guys that do a little bit of pulmonary hypertension. They don't have a huge dedicated time to it, and the support is, here and there. Or in some major centers here in the Twin Cities or south of here, it's its own entity, it's supported, and it's encouraged, the research is encouraged, the backup is there, and we'll talk about all of that here. So this is a picture taken immediately off of the Pulmonary Hypertension Association website. And these are what are called the accredited pulmonary hypertension centers or accredited centers of excellence. There are two tiers, and again, we'll talk about these more in details. But I wanted to show you a map of where pulmonary hypertension, these are about 50 something centers, and this is out of the thousands of medical centers that are in the country. And you can see here between Minneapolis and Seattle, there's nothing. It's a wide open area. Are there some providers here? I know there are. I know maybe 2 or 3 providers. I know them by name. I know their kids' names. I know them personally. They do some pulmonary hypertension care, but they struggle a lot. And so it's a wide open area of need. And I think we can do, and we should do better. So why is pulmonary hypertension care so lacking in the United States? It's because, in my humble opinion, and I can't speak for everybody who takes care of those patients, but at least in my experience, there are multiple layers of challenges that are related to, and we'll talk about that, challenges that are related to the disease process itself. First, as we talked, it's poorly understood, not only by lay people, it's poorly understood by the so-called experts as well. When you go to meetings, you listen to so-called experts, and you're like, I don't agree most of the time about what's going on here. And we've had the guidelines have took a while to get updated and really reflect the new way of thinking of pulmonary hypertension. And I'll explain something. People always thought about pulmonary hypertension in terms of the pressure, of the pulmonary pressure, and people still think about it that way. And clinical trials are still designed that way, where we're selecting patients for therapy based on their pulmonary pressures. And then, you get patients with World Health Organization group 2, and you put them on treatment, and then they fail treatment, and then you declare the treatment as a bad idea. They did that for a long time with pulmonary patients. Pulmonary patients, if you talk to a pulmonologist 5 years ago, they'll say, absolutely, you cannot treat them with pulmonary vasodilators because they get worse. And you're like, yeah, some of them get worse, but there's a group of them that actually gets better. And we've treated them, over the last 8-9 years since I've started training and doing pulmonary hypertension, and they did better. Finally, a clinical trial came and proved the concept, but you now have to think about it and how to choose patients and select patients. And so now the indication for treatment has expanded into interstitial lung disease related pulmonary hypertension. But for 20, 30 years, there's this strong concept that if your patient has some lung scarring and you put them on sildenafil, you're doing them a really disservice. And that's not necessarily true. It's just how you choose those patients. So there is a lot of misunderstanding about pulmonary hypertension. It's finally unraveling. It's finally getting better, but we still have ways to go. And the disease is progressive, as I explained. It doesn't really go away unless, even if they were on, let's say, meth, for example, and they develop pulmonary hypertension, they stop it. The progression may slow down or stop, but it doesn't go away. The other layer of challenges is unique to the patients themselves. A lot of the time, most of the time, those are young ladies. And so they're disproportionately impacted, and they're young, they're active, they want to have kids, and it becomes really challenging to have this disease that they're going to have for the rest of their lives. This is not cancer that you cure and you go into remission. This is a disease you're going to have for the rest of your life. Most of the time, You're not supposed to have kids. You shouldn't have kids. And so it becomes really a psychological burden. And the internet reflects that. Anytime a patient is given the diagnosis of PH, they go online and they find all that. It becomes really, really difficult. And that's where support groups come in, and we have to do a lot better with that. The other aspect that's related to the patient is a financial burden. All medical diagnoses are financial burdens, but PAH is a particular financial burden because as we will talk about that, the medications are extremely, extremely expensive. And as I said, most practices do not want to deal with pulmonary hypertension. There is administrative burden related to the cost of the medications and the fact that they're perceived as rare patients. So why invest the resources to try to create a process or support a process that gets those patients through the financial stuff and the social stuff and the support stuff? It is certainly, it has impact on the patient and their family as well. The medications, there are now over 12 medications for pulmonary hypertension. They're complicated medications. Some of them are pills, some of them are inhaled, some of them are infused under the skin or infused intravenously. They're all delivered from specialty pharmacy. And so most pharmacists out there, you can't just walk into CVS and grab your pulmonary hypertension medications. They tend to be complicated pills. This is not, Entresto or Jardiance or something like that. They tend to be, there's a specific set of skills and knowledge um, and side effects profiles and interactions. And so there are challenges related to the medications themselves. And then to the economics of the disease, again, it's perceived to be a rare disease. It's probably underdiagnosed. We've established that. But the medications are very expensive. The coverage, I'm not going even to go into details, but it can be really challenging to get patients on treatment. There are things that we can do sometimes to help them, but it tends to be challenging as well. And then it has to do with the center and the facility. So if you initiate treatment, for example, I was at a center where I would see a patient. The patient is pretty sick. Clearly, they need parenteral therapy. The right thing is to do parenteral therapy, but if the center doesn't do parenteral therapy, then you have to transfer the patient somewhere else. And at the time of COVID, transferring is no longer an easy task. And so it becomes particularly challenging to initiate treatment, the right treatment for patients. And that's why more than half of patients die without getting the right treatment, because the providers, even if they recognize the problem, even if they understand that they need to escalate the therapy, they're afraid to do so because there's no support, there's no endorsement of this therapy. And so that also presents a specific layer of challenges. Sadhguru, whatever, you can think whatever you think of him, but he sometimes comes up with good quotes. And sign of intelligence that you are constantly wondering. Idiots are always dead sure about every damn thing they're doing in life. Yeah. So the solutions, first is to recognize the problem. I know we have to acknowledge, okay, there are a lot of PH patients out there. We're missing the vast bulk of them, and we're not doing a good job at treating them, even when we recognize the problem, and we're not doing a good job, essentially, at least in the United States. But I tell you, it's the same thing in Europe as well, and everywhere. And so the solution is to build a team and support it, at least on an institutional level. I'm talking what we can do. We'll talk about that. So what does it take to build a team? And I'll talk from my experience, but also I've talked to Barry Cabway here and to Emily, his PH nurse, and I'll try to bring in a little bit of their experience too, because it's important to know, because MHI does have a pulmonary hypertension program. So who is the team essentially? The patient is number one, uh, and we talked a little bit about what are patient factors that are included or are relevant to this team. You want to know, if the patient lives alone or not. This is a big one, especially if you're contemplating therapy that is beyond just oral therapy. Is the patient psychologically able or stable enough to take medications and to follow up and to take instructions and directions? I've shared a patient with the University of Minnesota when I was in St. Paul, who him and his brother had some unusual heart disease. The brother was on milrinone infusion, and this guy had advanced pulmonary hypertension, and they're both cognitively impaired, and they're cared for by their mother. They're 40 years old, but they're cared for by their mother. So imagine the challenges every time this patient comes in and you realize they're undertreated and you want to add more therapy, and you're just thinking in the back of your mind, how is this going to happen? How is this patient going to keep receiving escalated levels of care, whereas he's essentially an adult that is cared for by a mother, and his brother is on milrinone infusion at home? So it becomes really, really challenging, and you wonder, okay, why are people undertreated? Because there are many, many factors to consider before escalating those therapies. If you're going to do inhaled medication 4 times a day, or even worse, if you want to do infused medications, that becomes really challenging. So this is what the team is about. The team is about trying to figure out solutions for those patients. Family support is absolutely, absolutely important. And, the heart failure guys are very well versed in that usually, because, when they, deliver advanced therapies, they want to see family support. But, here obviously talking about lifelong medications, lifelong disease entities. So you do need, you do need to establish that family support. I had a patient, again, when I was in St. Paul, who had meth-related pulmonary arterial hypertension, young lady, but she was homeless. And I'm sure they see that at the university a lot. So how do you treat a patient with $300,000 worth of medication and they're homeless? Even if they had Minnesota Care, Minnesota is much better than other states, much better than other states. But how do you treat them with those medications and they're homeless? She has no house. She lived with her husband out of their pickup truck. And so those are issues that you have to deal with. But she made it. She's doing really well. Insurance. Oh my God, that's a topic. But anything you think about of insurance, of terms of any medications you prescribe to patients, you just multiply that to the 5-10 folds. Those are the problems, exaggerated when they have PAH as opposed to other medications, because even if you have insurance, sometimes it's just not good enough at all. Specialty pharmacies are the only pharmacies that really deliver the bulk of pulmonary hypertension medications, with the exception of maybe sildenafil or something like that. But they are extremely important part of the care of pulmonary hypertension. And they could make your life real easy, and they can make your life real difficult. And it has to do with the individual staff members themselves. And so you have to know them in person, you have to trust them, and you have to get feedback on their services from their patients, from your patients, essentially. Industry can be very, very helpful for us. I've worked with industry and they've helped me educate community providers. I used to go out and give talks to primary care doctors who wanted to learn about the disease process because you want to capture those patients. So industry was, to me, at least in North Dakota, was very helpful in spreading the word to the community about pulmonary hypertension. They can help educate your staff as well because they have a lot of resources about the disease process. It doesn't have to be about the medications themselves, but they would help you with that. They can also obviously help you access research, but you always have to be cognizant of the conflict of interest issues. Nurses are the core of most pulmonary hypertension programs in the country, including in this center here, because they do most of the day-to-day care of pulmonary hypertension patients. But it's very important, and this is again in my experience, is to get the nurses invested in the process, meaning there's a lot of work, right? We just talked about how complicated the social issues, how complicated the insurance issues, how could be frustrating. But a well invested in nurse, empowered, I used to take them to the pulmonary hypertension conferences, not on their own dime, have pushed the center to pay for their education. They led the support groups. They become invested. They like pulmonary hypertension as much as I do, and they care for those patients as much as you do because this is an extra level of nursing. Okay, it's just an extra level of complexity. So it's very, very important that your nurses are empowered and supported that they can do this. This is not something that like the nurse up in Baxter, she's doing a wonderful job, but she only has 2 days a month to do everything. She's never been to a conference. She's never been, and so it takes more encouragement. It takes more involvement, even in research, community outreach. Nurses have very good reputation with patients, and you can use that to create a good reputation for the program as well. Coordinators, and this could be the nurse themselves, but they could be administrative coordinators who are not medical, but they can help with the paperwork, meaning the nurse can spend time doing clinical stuff instead of just filling out paperwork, and that we had in Fargo, and it worked marvelously. It helps the nurse to feel that she's working to the level of her degree, and that's when the nurse goes above and beyond when she doesn't have to do the paperwork, because this is really not what she went to school for. But most places, the nurses end up doing the paperwork. Pharmacists can help with obviously medications, medication complications, medication side effects. I know there are pharmacists here that help Emily in some of the prior authorizations. And they're usually a great resource to the patients as well, who's can be not only on pulmonary hypertension medications, but they can be on other medications as well, and so they can help them with that. Leadership obviously can make it or break it. The commitment of the organization to the treatment of pulmonary hypertension, and not only treatment, but really comprehensive care of pulmonary hypertension, can make it or break it essentially. And not only with the relationship with the providers of pulmonary hypertension care, but also encouraging other departments to collaborate and to support the pulmonary hypertension program. And so it depends on the organization. I can make it or break it, and certainly I have seen that. Politics in the country, politics in the state, it all has something to do. I'm just going to throw it out there. For example, it depends on which state you are. If a pulmonary hypertension patient is pregnant or not, it's going to make a huge difference. I'm just going to leave it at that. It's going to complicate things a lot for pregnant PAH patients in North Dakota versus Minnesota. There's going to be a huge difference there. And now the pulmonary hypertension community is sensing that. We have an online thread with between all pulmonary hypertension providers in the country, and you can sense after recent decisions, there's fear, there's a lot of discomfort in a lot of states, unfortunately, related to some recent political atmosphere. In particular, when it comes to pregnant patients with pulmonary hypertension. APPs, obviously, same as nurses, they need to be invested in, they need to be supported, they really need to have passion for this because they can be really. I learned more from Fran Rogers, who's the NP with Paul Forfia, than I learned from him probably, because all the practical things about the medications you learn from them. And doctors, there's no training specific, there's no accredited program, let me just put it that way, for pulmonary hypertension. And so it becomes more of a personal effort. You have to go out and seek the training. There are some training programs that are not accredited. For example, Mayo has one. I know Temple now has one. Where they can train you on pulmonary hypertension. But pulmonary hypertension specialist, the way I like to think about it is it could be either a pulmonologist or a cardiologist. But to me, I like to call them cardiopulmonary specialists, because you have to have skills that are not just taught in cardiology and that are not just taught in pulmonary. You have to have skills for example, for a cardiologist, you have to do some extra time in the cardiac ICU, but you also have to spend time inpatient and outpatient pulmonary hypertension service, and you have to spend time in the hemodynamics lab, in the exercise physiology lab. You really have to know how to do cardiopulmonary stress tests and interpret it on your own. But you also have to spend time in pulmonary clinic. Like if a pulmonologist sends you a patient and say, hey, look, this guy has pulmonary hypertension, and you look, you're like, no, well, he has really bad ILD, and I think, the pH is proportionate, and they say, no, it's not proportionate. You have to understand how to look at PFTs and lung scan on your own to be able to actually come up with the right plan. You can't just take their word for it and run with it. You have to have the expertise. You also have to understand if you have a patient with pH and positive ANA, you have to have a little bit of extra knowledge and, okay, what type and what does that mean? And are they going to, progress or not into developing the full phenotypic rheumatological type? And so there are certain skills that cardiologists were not equipped to do that unless you spend time in the lung transplant clinic, unless you spend time in the ILD clinic, unless you go to an ILD conference once in a couple of years and talk to pulmonologists and know that. And the pulmonologist, I mean, if you're a pulmonologist that wants to do pulmonary hypertension, you have to know how to look at your own echo. You have to look at your own tracings. You have to be able to do that, because most cardiologists who do right heart caths are not pulmonary hypertension cardiologists. So there's certain things that you need to do in the lab in order to get the relevant data with pulmonary hypertension patients. And if you're going to be a comprehensive care center, we'll talk about it, you have to have seen some chronic thromboembolic pulmonary hypertension patients. You have to have seen CT angiograms and know something about how to look at pulmonary angiograms and things like that. And you have to have done pulmonary hypertension specific research. And I'll just show you here why that is. Okay, and a pulmonary hypertension specialist, I think has to talk about pH, has to support pH, has to go out and educate the community about pH. It has to have a dedicated time for pulmonary hypertension. There's no two ways around this. It has to be a dedicated time. It just cannot be, you know, hematologists, oncologists do everything, and then expect them to deal with, a particular set of skills. They have to have the dedicated time. And so, because of all the complexity and all the difficulties I presented to you, the guidelines recognize that. And they want pulmonary hypertension patients to be cared for at centers of what they call them excellence. They don't want pulmonary hypertension patients to be taken care of anywhere because they know they cannot get the care. So the guidelines want to centralize the care of pulmonary hypertension at expert centers, but they realize there's only so many centers. And so there has to be what we call a robust outreach strategy, meaning there's a center of excellence, and that center of excellence connects with many providers out there, and those providers are very competent. They may not do the full bulk of service, but they're able to connect very easily to the central center, for example, for parenteral therapy or something like that. And then those patients get initiated and sent back to the community, and those centers are supported. So there are two tiers of centers. There are comprehensive and regional care centers that are suggested, and there is an accreditation process that involves evaluation for those centers, where their director is evaluated to a certain standard, the coordinator, and all the staff and the facility um, availabilities, and their research activity. And Pulmonary Hypertension Association has two tiers, like I said, Center of Comprehensive Care, for example, versus Regional Clinical Program. There's a doctor at United, a pulmonologist, who on his own initiative, I was introduced to him on Friday, and he's working on getting a regional clinical program at United. And I think we ought to support him, and we have to partner with him, being he's an Alina guy. Um, but he's on his own. He's doing his own thing. And so he's like, I talked to him. He's like, I haven't had a single cardiologist attend any of our PH meetings. I'm like, how is that possible? How is this possible? How do we let that happen? Um, but so we could do better. I do think MHI, right now we don't have any designation. I do think the way we are right now, we probably can get to a regional program designation, which, like I said, United, their pulmonologist is doing that already, so he's ahead of us. But honestly, I was asked when I interviewed here, Ritu, I think, asked me, she said, tell me your goal in 5 or 10 years. I said, we gotta get the comprehensive center designation in the next few years. We have to do that. Um, and I know I talked to Barry, and Barry was working on this before the pandemic came, and that kind of set it back a little bit. But I know for sure that he was working on that and that he can get it. I know that he can get it. But, there are certain criteria. Some of it has to do with the individual provider, being involved in education and going out there and talking to people and educating the staff, educating the community, speaking at conferences. They have to have that commitment. CME. The coordinator has to be a dedicated coordinator with more, one FTE or more. Could be multiple people satisfying that requirement. Um, like I said, the time commitment, it has to come from the practice. Practice has to allow the director of the pulmonary hypertension to be 0.5 FTE or higher. They come in and look at the program. They come and look at the program and they ask him, what else do you do? If you're doing 10 things and PH is 1 or 2 weeks, 2 days, a month, that's not going to satisfy you. And you don't want that. You don't want the comprehensive center and you say that you do everything about PH and then you spend 2 or 3 days a month only. They need to be given protected time, not only for clinical care, but for research and for education. And so there are those requirements. They want 0.75 physician FTEs can be satisfied by multiple physicians and should be multiple physicians, frankly. But at least 0.5 of it is the director themselves. And there's numbers of research publications that have to be satisfied. It's not very huge. It's not very huge. There's 3 IRB approved pH investigations within the last 3 years. It should be doable. It should be doable in order to qualify as a comprehensive care center. So is the designation important? I can tell you, Emily, I talked to her, and again, she's Dr. Cabway's nurse. She said patients are asking about it. Patients are asking. They're coming and they're saying, why aren't you accredited? Should we move somewhere else? Not my words, those are her words. So I think people go online and they see this map and they want to know if they're being cared for at a company. I know that they care for PH patients much better here than anywhere else. I know Barry, I know they're excellent team. They know everything about PH, but people want to see that the center has dedicated the time and resources that they recognize this is a big deal, because for those patients, they want to be at an accredited center. And it just reflects the commitment of the center. So I'll leave you with this quote from Bernard Shaw: "The reasonable man adapts himself to the world. The unreasonable one persists in trying to adapt the world to himself. Therefore, all progress depends on the unreasonable man." And I'll take questions.
Thank you for that talk.
Thank you.
Is there any progress on earlier diagnosis? You pointed that out earlier in your talk. I mean, the disease is characterized by the elevation in the pulmonary artery pressure, yet the disease itself is beyond that. So,
yeah, absolutely. No, unfortunately, outside of high-risk individuals, especially rheumatological patients, there are no set criteria for screening for early pulmonary hypertension. The one thing when I went out to communities and tried to talk to primary care providers, I think the cardiologists can do a better job at reading echocardiograms, because pulmonologists say the same thing. They're somewhat frustrated because of how we read echocardiograms. And I'll just give you the example of pulmonary pressure estimation by TR jet velocity, a horrendous way to screen for pulmonary hypertension. And it actually it fell out of the guidelines for pulmonary hypertension, at least. We don't talk about pulmonary pressure estimation by echo. We talk about risk. You stratify them as risk groups. For example, if the indication of the echocardiogram is screen for pulmonary hypertension, the guidelines, at least the European guidelines, want you to report the TR velocity in light of the RV size and function. So, as you know, you could have mildly high pulmonary pressure, but a RV that's pretty bad, then that patient has advanced pulmonary arterial hypertension. And so, and you could have really high pulmonary pressure, 50 or whatever, but the RV is really good, and that has different connotations. So the cardiologists have to feel a little bit more confident when they read an echocardiogram to help the referring physician understand what this echo means, and not just to report a number. And that's why, especially knowing that the number is a lot of times off based on the TR jet velocity. I, for example, have been taught, and I do it all the time, if the TR jet velocity is not perfect, meaning perfect, not just the envelope is full, but it's very parallel and all of that, I just call it inadequate for assessment. Because it can, especially if it's abnormal, and let's say the pressure is coming out as 25 only, but the RV looks bad, I don't report it unless the jet is very, very accurate. So we have to help people when they send patients for echocardiogram looking for pulmonary hypertension. We have to try to give them a little bit more than just a reported number that the tech, points at the jet, and you just take whatever number and you just say plus right atrial pressure. I think this, since the echo is the screening modality, the echo readers have to do a better job. And in building a program for pulmonary hypertension, one of the first things people do, and I did, is to revamp the echo protocol in order to be more specific for pulmonary hypertension. For example, as far as reporting the pulmonary estimated pressure, but also make sure you report the septal position, right atrial size, and the Doppler parameters of the right ventricular outflow tract, because that's much, much, much more informative than just the pulmonary pressure. So there has to be a lot of work done on the cardiology front to support a pulmonary hypertension program, and a lot of it is done in the echo lab. Most of my research in pulmonary hypertension was on the echocardiographic characterization of pulmonary hypertension, because you could, it's a non-invasive cath essentially. You could get a lot of information, and so that's part of when I said that pulmonary hypertension has to be rethought of beyond the idea of pulmonary pressure. This is how we capture those patients. A lot of it is education too. I've seen many patients that come in with significant RV problem, and the first thing that the provider thinks of is sleep apnea. I've had so many patients with advanced PH that are being brushed off as sleep apnea, and I'm like, what kind of sleep? It has to be asleep all day long to get that much pulmonary hypertension. I mean, I'm just going to tell you, sleep apnea does not cause significant pulmonary hypertension. So don't ever see a dilated right ventricle and call it just sleep apnea. Okay, if they're Pickwickian, if their CO2 is really high, their obesity, hypoventilation, sure, maybe. But that's after you rule out other stuff. So there's a lot of education that has to happen. There's just so many things I could tell you about the calcium channel blockers. The bane of my existence is people still think of calcium channel blockers as treatment for pulmonary hypertension. It's just, there's so many things that need to be thought of, and rethought of, and re-educated, and starts with cardiology. Cardiology really has to start the process.
A more mundane question, how do you define pulmonary hypertension? And when should a patient be referred? I'm a practicing cardiologist. When should I refer to a pulmonary hypertension specialist?
Yeah, thank you. Pulmonary hypertension for cath, as you know, for the mean has to be above 20 now. It used to be 25. It turns out that 25 is more than 2 standard deviation above normal, so 20 is the new cutoff for mean, and that's by cath. And people always forget that, because I see echo reports calling PA systolic pressure 30 as pulmonary hypertension. That's not true. Like I said, the guidelines shied away from defining pulmonary hypertension by pulmonary arterial systolic pressure, because there's a lot of variability in the right atrial pressure estimation. Alex Gamble is not going to like that, but we don't believe that IVC assessment is a good way to assess right atrial pressure. And so they want you to use 2.7 meters per second for TR jet velocity as the cutoff, plus signs of right ventricular dysfunction or enlargement. So let's say 2.7 or more, you can say suspected pulmonary hypertension. If you have 2.7 or more plus right ventricular enlargement, septal flattening, then you got pulmonary hypertension confirmed, essentially. If you have diastolic dysfunction plus 2.7, also you have pulmonary hypertension. And so 2.7, just think of it in terms of echo jet velocity, 2.7 meters per second, that's where you start. But again, if the jet velocity is 2.5, but the RV is dilated, you have to write suspected pulmonary hypertension. So that's as far as the definition of pulmonary hypertension. It's both the pressure and how the right ventricle is doing. And we just have to think that way. And as far as referral, I would say, as a cardiologist, you're looking at the echo and you see if the pressure is explained by the left side dysfunction, you don't have to refer them. You're welcome to. If the left atrium is big If the left ventricle is stiff, if there's valve disease, and the right ventricle looks relatively okay, could be pressure of 60, but you know this is postcapillary, or at least is a mixed pre and postcapillary. And so you have to fix the postcapillary component first. But if you suspect that based on the echo, the right ventricle is disproportionately enlarged, then this patient should come to pulmonary hypertension clinic. So the echo is instrumental, but the least important parameter on the echo is the pulmonary pressure. That's the least important one because it could be off 50% of the time. The TR jet underestimates by 20 millimeters or more the pulmonary pressure. So you have to put it all in line. The cardiologist should do that. No one else can do it, really. Cardiologists should do it. The one who's reading the echo, when they see this high pressure, they should try to put in the report, try to characterize it a little bit more for the referring physician. Give him a little bit of a sense of what this could be. You don't have to give the full diagnosis, but at least give them hints. Okay, because the septum is flat, because the RV apex is wide, this is most likely going to be precapillary pulmonary, and further investigation is warranted. Or you get a dilated cardiomyopathy, 20% with wide MR, and you get a PA pressure of 65. You're sending a report out to the community. You have to tell them this is most likely postcapillary. Otherwise, they see pulmonary hypertension, they add it as a separate problem list on the diagnosis, which is not. But that's okay. I mean, I'd rather see those patients and say that they're not precapillary than not see them or find them. But I guess it starts with cardiology. The echo lab is really, and for the cardiologist, is looking at the echo and saying, okay, there's pulmonary pressure. Is this the disease, or is this the consequence of the disease? And if you feel that it could be the disease, that's when you send them to the PH clinic. Thank you for the question. Thank you.